move on to another question. Gentleman in green.
Hi, my name is Steve Holsworth. I'm with St. Louis Center for AIDS. My question is about the exchanges. And basically, first, there's two parts. One, is there any chance that Missouri is actually going to make their own exchange in the timetable that it is and the lack of action at this point? And two, who benefits if the federal government comes in and says, okay, here's the Missouri exchange versus Missouri develops their own? Are there winners and losers in each of those scenarios?
That's a great question. So the first part of the question is, how likely is it that Missouri will create its own state-run exchange? And then the second part of the question is, who are the winners and losers, depending if it's a state-run exchange or if we are one of the states that has the federal government run our exchange? So who'd like to take that question to start with?
Sure.
Okay, go for it.
I'll comment.
Yeah, it's even if Missouri decides to proceed right now, they're behind the curve. I mean, there are a couple of states, California in particular, who's been on this for months, and they're going to struggle as well, I think, to get it up and running effectively. But there are models out there that are already working. Massachusetts has an excellent program that's working well. The federal government actually initiated and issued contracts for developing the exchanges in January of 2011. And they have 3 large organizations who have significant experience in setting these up, both from a technology standpoint as well as from the navigator, the communications that needs to be readily available between all the parties that are participating in this. So I think the federal government will likely be ready with their exchanges. How effectively they're going to have negotiated then with the insurance companies in those states where the feds are taking over to make sure that they have a robust opportunity for participation and good management of those insurance companies that are participating, that remains to be seen. The devil's in the details with that. In terms of who's going to be a winner or loser, if the states are managing it, they can control most of their requirements for which insurance companies are participating or not, some of the requirements that they will have around eligibility provisions, a number of things that they can control more directly. If the feds do it, then the feds are going to use their regulations, so the states will have less control over it. Now, the feds have also said they will do not just an all or nothing, they will partner with the states who may not be able to get the technology up and running and have the navigators running, but they'll let the feds do that piece, but let the states actually manage more of the participation of insurance companies in the program, things like that. So it depends. There are winners and losers in both.
But Tim, who are you using as an example of a success story? Massachusetts would already be in bankruptcy. Many of their towns and municipalities and school districts would already be in bankruptcy if it were not for the $26 billion that they just received from the federal government this last year. So they are struggling. They've had an exchange-based format since 2007. They still can't make it work. Every state in this country that has tried it has failed, and it has cost them an excessive amount of money to get out of it, and also it has reduced the market availability of insurance in every state that they've done it. We have an office in Seattle, so I can speak to Washington, and they tried this model in the 90s. They had people coming up from California and all across the country to get basically free care because they were automatically eligible if they signed up. Consequently, what happened was the insurance companies went out of business, they left the state, and they still haven't come back in their full iteration. They are now working through trusts so that if they have to pull out of that state again because of laws that force them to spend too much money and lose money, they can do it effectively. So they're also one of the states has implemented a state exchange, and will have it fully up and running by 2014. So I don't know what makes them think they can get it done this time. So please tell me where a success story lies.
Well,
Universal is
the question was whether it could be administratively set up and running, whether it's funded properly, and whether it's managing cost of health care is a totally different issue that I don't know that we can address
But
yet.
if it's not financially stable, then everything we're doing is just a waste of time and money.
But isn't that an argument for the reason that it should be done universally across all borders as opposed to isolated states, because one of your major arguments was that people were moving from another state
Right.
into a state that was
Right.
providing coverage for all of its
But
citizens.
when you
So if every U.S. citizen has access to affordable health care, then there will be no reason for them to move across state lines.
True, but when you reduce the barriers in terms of cost, when the cost is free,
It's not free.
it is free for those participants who are making the decisions to go out and get care. If they are on, if anything under 400, anything at the Medicare level, so we have an additional 15% of the population, right, that's going to automatically going to have access to care, correct?
And for none of those people is it absolutely free. Up to 400% of poverty, you are eligible for a subsidy, but you still have to pay, and it's a significant
Right.
skin in the game for those participants. It's not free for anybody.
And it's not free for us, because all of our premiums go up.
When
All of us
those people are uninsured.
All of us are paying, and there's no accountability for that additional funds that we have to pay. So just so everybody realizes, in 2014, the insurance company, as one entity of the additional tax, the insurance companies are going to get a prorated bill for $8 billion. So you all can look around and look at the insured, and you can figure out that that's going to be about $50 per head that's going to be tacked onto your insurance bill. And so what happens is, as these insurance costs go up, and I have clients now who are making a decision based on the law between health insurance and the number of jobs that they're going to have available.
So this is an equation. I think the important thing being that it's going to be across state lines. The important thing being critical mass. But so the question the gentleman asked, will the state-based exchange be an active purchaser or a non-active purchaser? That is, will they go out and get a benefits package that has many components to it, or will they stick to the basic federal minimum? And when we talk about winners and losers, there's a fine line between having the right amount of insurance and being overinsured. And when we begin to think about what is the best insurance package to get more people into the exchange, to get a critical mass that makes sure that it's able to cover its costs and it's a good insurance pool, these are all questions as to whether the exchange gets up and running, is functional, and gets to those cost savings.
I want to move on to another question. The gentleman in blue had a question.
Well, yeah, it had a couple things. One, you talk about the rebate that you get. Well, I'm with Kevin Conley, agency principal, Conley Benefit Services. I'm an insurance broker. I have a personal plan with Anthem. One day I got my check for $140-something for my rebate. The next day I got a letter saying my premium went up $70 a month. How does that work?
Can that be attributed to, do you think the ACA caused the price to go up?
No, but it just has to do with the fact that the rebates are just BS.
Let me ask you this, did you cash it?
No.
You didn't cash it,
What
okay.
about personal responsibility on any of this? The one thing I keep seeing is that we're going to pay for everyone's care no matter what they do. Where is the personal responsibility? As someone who takes care of myself, my body, doesn't eat fast food, runs, does everything right, why do I want to pay for the person not next to me, but
Sure.
that doesn't do any of that? Yeah, that doesn't do any of that. That is obese, like over 30% of our nation is. I don't want to pay for everything. What about smokers? Are they all going to pay more?
Okay, let me repeat your question. So the question is, where's the personal responsibility? If we pay for everything, should there be penalties, perhaps, and these are my words, penalties perhaps on folks who are overweight or who smoke or who engage in other unhealthy behaviors so that the healthier folks aren't subsidizing them?
Speeding tickets.
Well, I'm glad you asked the question, because one of the things that the ACA does do is it really is an opportunity for a paradigm shift. Right now, this country is based on sick care, not on prevention and wellness. And there are specific provisions within the ACA that does, in fact, allow for those things to happen. So that, for example, one of the things that's already gone into effect is the preventive care coverage within Medicare, and the requirement, I believe, 2013 across the board.
But again, the penalty's going on the ACO, not on those individuals.
No. I'm sorry?
Isn't the penalty, though, going on to the ACO, not on those individuals that are in? I mean, the doctors can say all they want, can tell their patients, you need to be healthy, you need to do this, you're pre-diabetic, you're pre-whatever. The patient has no incentive.
Yeah, I'm not even talking about penalties. I'm talking about the access and opportunity to access preventive care. And by so doing, hopefully, you'll prevent the actual the disease down the road.
So can I bring up, so you just said something that was very insightful. You said, I think it's bigger than that. It is absolutely bigger
They have
than
to
that.
get to the cost, and none of that is being
So
addressed in
when
the budget.
we sat down, Bill and I sat down to talk about this presentation, we ended up the conversation about our food policy. We ended up the conversation about our education policy. We ended up with these global issues that were not just related to this healthcare law. So the fact is that there is a great deal in this law about personal responsibility. There is a personal responsibility to go to your physician, to see your physician early and often. The doctor is not going to get paid on whether you manage your diabetes or not. The doctor gets paid on whether they prescribe the best practice or they did the best course of treatment. But we have a problem in this country. Many people do not know how to access the healthcare system. They think the emergency room is their access to the healthcare system. Maybe that's because we've been underinsured or uninsured for so long as a nation.
Well, no one's explaining it to them.
And no one is
What-
explaining to it.
What
And
the MLR is doing is taking the brokers out of the equation, who are the one person who's in the field every day helping the clients figure out their claims and their claims issues.
Well, I think
So-
we've gotten a
in
little
fact,
bit
I think
past
there
the
is-
original question, and I want to make sure we've got time for one more. So,
No, I got it.
Yeah, Don Wells, Aegis Health.
Keep dropping this thing.
My question to the entire panel is, do you really believe that we're going to be able to make the system achieve the savings that are going to be necessary to avoid wide-scale rationing that we already experience right now, in particular for older adult health care? The hospitals have no experience in older adult health care and managing chronic diseases.
so the question is the Affordable Care Act going to really reduce costs enough to avoid continued rationing?
Devil's in the detail.
All right, Bill, why don't you go first?
No. If you own a company and you have 100 employees and only 60 of them are participating on your health plan, however, next year you're forced to buy a plan that is going to be a little bit cheaper, but with the proviso that you have to cover all 100 employees, are you spending more money or less? There's no way to, there are too many people out there, and we don't have enough freedom in the markets for them to take responsibility. We need freedom in the access to care markets for providers and hospitals. We need freedom in the insurance market so that people they can make their own decisions, because they are going to effectively use the money or the policies that they buy to secure their health care. And it-
I don't want to disagree, because I happen to agree no. And we're nonpartisan, and we can tell you 10 great things about this law, and we can tell you 10 terrible things about this law. But I would pose this question: can we afford not
That's
to
the issue.
have this discussion? Our insurance premiums are going up. This gentleman right here points out that the health of Americans is declining. We have problems with quality of life relative to managing chronic conditions, acquiring chronic conditions. If we don't do something now, are we going to be having this same discussion 25 years from now, 50 years from now, and more of us will be uninsured and most definitely underinsured?
Well, unfortunately, that needs to be our last question for right now, but all the panelists are going to be staying, and so if you have a question, please feel free to come down and chat with them, and I'm going to turn it over to Ellen for some closing comments.
Please join me in thanking our panel. And I think that Mary Jo gets a particular thank you for being a really wonderful moderator with a very large crowd. Our panelists have agreed to stay, so I know that there are other questions for them. We just want to be respectful of everybody's time. Thank you for joining us this morning.